I know it's time for everybody to relax, but this is it. In all conferences, last session has to come. This is the beautiful medical college I come from, Shimoga Institute of Medical Sciences. Now the big question is, what is the choice of anesthesia for cesarean section in preeclampsia? In the next 14 minutes or 15 minutes or so, I would like to answer this question if possible. Dr. Sunil, my friend, has already mentioned about this particular article, the report on the confidential inquiries into the maternal deaths. In that they ask a question, why mothers die? And the maternal mortality rate that is directly attributable to anesthesia has been reducing drastically from 1972 onwards to 1990. So what was about 12.8 per million in 1972 has dropped to around 0.5 per million in 1999. Now, what has made this difference? There is a dramatic fall in the anesthetic deaths. Man in Stone Age used to walk a lot of distance. Maybe he had an animal after some time, a bullock cart, maybe a bicycle, a motor vehicle, after that a locomotive, a ship, and a Formula 1 car now. Now, what has made this difference in the evolution of locomotion? One invention, the invention of a rotating wheel, has made all this difference. Now, what has made the difference in the reduction of anesthetic deaths in obstetrics in such a short period of time, maybe in 2 decades time itself? The difference is enormous. Now, probably the two things have made the difference. Number one, that made the difficult airway management not at all mandatory, the regional anesthesia, the spinal and the epidural anesthesia. And the number two, which has made the difficult airway management more easier, which gave a rescue airway in the form of an LMA. Now these two things has made all the difference in the reduction, the drastic reduction in the anesthetic deaths altogether. Now the incidence of, if you look into the incidence of general anesthesia which was given to preeclamptics in 1970, about 74% of the preeclamptics received general anesthesia, which started falling drastically, and today in 2013 it is far less than 5%. If you administer general anesthesia for a preeclamptic more than 5% of the times, people are going to ask you, why is it so? Now, what are the concerns in general anesthesia in preeclamptics? The first and the foremost is the hypertensive response to laryngoscopy and intubation in an already hypertensive, and its consequences like CVA, pulmonary edema, myocardial infarction, etc. Now this is one of the most important concerns, and that's why probably people have started shifting. The second one is the uteroplacental blood flow. Now if you see the normal placentation during normal pregnancy, the trophoblastic cells try to invade, these trophoblastic cells tries to invade the tunica media of the spiral arteries, and the spiral arteries become a single cell layered sac-like structures which are totally low resistant vessels. So that's why the effect of the sympathetic stimulation does not have any effect on the uteroplacental blood flow during a normal pregnancy. Now if you see during preeclampsia, what happens is at the time of placentation itself, this invasion of the trophoblastic cells does not take place. Even at term, the spiral arteries are muscular. Now because of this particular reason, they respond to the sympathetic stimulation. That is why under general anesthesia, the uteroplacental blood flow drastically reduces. Whereas under regional anesthesia, because of the sympathetic blockade, the uteroplacental blood flow is going to increase, and that's going to be advantageous for us. Now going to the next advantage, of course, you all know that during pregnancy, the edema all over the body in the airways take place, especially in preeclamptics, and because of that, the difficult mask ventilation, intubation, its consequences, regurgitation, aspiration, and this is what we don't want to have. Can't intubate, can't ventilate situation. Now all these things are a possibility if you administer general anesthesia. Now the last but not the least, the effects of anesthetic agents on the fetus and the newborn, deleterious effects, and on the myometrium, causing myometrial relaxation and the postpartum hemorrhage. Now these are all some of the disadvantages of general anesthesia. That is the reason why people started thinking otherwise. Now but then, even under spinal anesthesia or regional anesthesia, there are a few concerns. The most important one of them is the precipitous hypotension and bradycardia. We all think that the spinal anesthesia causes precipitous hypotension, especially in hypertensives. But people think otherwise. You see, these are some of the recent articles in Anesthesia Analgesia in 2003 and the same continued article in 2009. They have said that the patients with severe preeclampsia experience less hypotension during spinal anesthesia for elective cesarean delivery than in normal healthy parturients. And this is a prospective cohort study. It is still continuing, and they definitely say that the difference is enormous. In hypertensives, you give spinal, the incidence of precipitous hypotension is very, very minimal compared to normotensive subjects. And this is not new. There was an article way back 50 years ago where he used 0.2% procaine with a continuous subarachnoid catheter, and he said that there was negligible fall in blood pressure of normotensive non-pregnant women and in toxemic subjects. So this is not a new this concept at all, but it is true. The second concern is about PDPH. We know very well the use of spinal needles, small spinal needles, the use of pencil point needles have reduced the incidence of PDPH to less than 0.8%, so it is again not a very big concern. The next one is about the coagulation. This is what I marked it in red, the coagulation abnormalities and the subsequent neuraxial hematoma, which we are really worried about. But the point is that today we have some set protocols to say that this patient can receive spinal anesthesia, epidural anesthesia, this patient can't. Now this kind of a set protocol, you need to have your own protocol which is guided by the set protocols by ASRA and other associations. The most important thing is in a preeclamptic, even in an emergency, if it has come to you either for a labor analgesia or for a cesarean section, get the platelet count done. If the platelet count is more than 100,000, no more tests are required at that moment. Go ahead and give your epidural or a spinal. If it is less than 100,000, get the other tests, PTINR, APTD, fibrinogen. If it is between 50,000 and 100,000 and other tests are normal, neuraxials are still safe, but prefer a single shot spinal, carefully administered spinal than an epidural anesthesia. If you put an epidural catheter, remove it only after the platelet count reaches 80,000. If it is less than 50,000, no neuraxials. And this is one of this definite indication, contraindication for spinal in preeclamptics. PTINR, you all know INR less than 1.5, neuraxials are very safe between 1.5 and 8, again careful spinal. Above 1.8, no neuraxials at all. If the APTT is prolonged or fibrinogen is very low, no neuraxials are given. So, we have tried to solve that problem also. Now the next one is some of the permanent neurological damage, which my friend Dr. Sunil mentioned about in 1930s, the two permanent neurological damage which occurred with the spinal anesthetic. Now because of that, people thought that the chances of permanent neurological damage after spinal is very high. But it is not very true. The better understanding of neuraxial anatomy today, use of finer pencil point needles, use of low concentration of local anesthetics, we have gotten away with 1% bupivacaine for spinal anesthesia. Today we use 0.5% bupivacaine. We rarely use 0.5% lignocaine. Very few people use it today. So because of all this, the incidence has drastically reduced. And a better use of better antiseptics in the form of 10% povidone, chlorhexidine, all these things have definitely improved our quality of anesthesia. The neuraxial infection rate has definitely come down. Now, so today we have tried to solve most of these concerns, and hence probably the choice of anesthetic for cesarean section has changed in the last 40 years. What was Mrs. Smith, which was pushing the trolley for her daughter, and her daughter is pushing the wheelchair for her today. What was only general anesthesia and no spinal 30 years ago, and today only spinal and no general anesthesia. So I would like to tell a few protocols, these set protocols for spinal anesthesia in cesarean sections in preeclamptics. Hydration, the standard guidelines of prehydration or cohydration, preloading or co-loading for cesarean section does not hold good in preeclampsia. You need to be very careful in giving fluids. Pulmonary edema is always a possibility. The dosage of local anesthetics, always go for a low dose spinal bupivacaine, and I'm mentioning only a standard drug. Bupivacaine 7.5 to 8 milligram intrathecally is all that is required. Hypotension is rare, but if it occurs, treat with very small doses of ephedrine or phenylephrine. Prophylactic phenylephrine has no role in preeclamptics. Use of a wedge is definitely mandatory. Sedation is of course desirable, but only after extraction of the baby. Post-operatively, analgesia has to be done, a proper analgesia has to be maintained, and monitor for post-op eclampsia. This is to be done very, very carefully. A team approach, you can't say that this patient, I have given spinal, I finished my case, I'm just walking off, it's the obstetrician's responsibility. It's not so. Or the obstetrician cannot say that it's my case, my patient, it's my patient, anesthesiologist has no role. It is not so. A team approach has always produced good results. A good company on a long journey makes it seem shorter. When I focused this slide in one of my workshops which I conducted, my good friend in the audience immediately asked me, who is the anesthesiologist, who is the obstetrician in this? Now there is a take-home message guidelines. These are taken from standard textbooks, and these guidelines are made by me. You take it as guidelines only, they are not standard, they are not biblical. So you need to know what best is in your setup is. Mild to moderate preeclampsia, the choice of anesthesia is single shot spinal with bupivacaine, say 7 to 9 milligrams, or a continuous epidural analgesia. In severe preeclampsia, you can go ahead with a combined spinal epidural with a spinal with a small, very small dose, 6 to 7.5 milligram, with a backup epidural. You have a backup epidural all the time, or a continuous epidural analgesia. A preeclampsia with coagulation abnormalities. This is one definite indication for general anesthesia. An eclampsia is no more a definite indication for general anesthesia today. If the patient is conscious, if you have a conscious patient who has had an eclamptic fit also, maybe you can go ahead and give a single shot spinal, a continuous epidural, or a CSE, or an eclampsia with an altered consciousness, again, is a definite indication for general anesthesia. So we are going to host the National Conference of AOA in Mangalore this year, October 4th, 5th and 6th. I request every one of you, please register for this conference. I'm not the host, but my neighboring city, Mangalore, are the hosts. So please do register. Thank you very much. Thanks a lot. I think I'm